Welcome to the Deep Dive. And today we're starting with something really helpful for pharmacy owners, especially those listening in Oxfordshire, Berkshire, and Buckinghamshire.
That's right. This deep dive comes with support from the great team at Community Pharmacy Thames Valley.
They really are a fantastic resource, aren't they? Helping navigate things like the Pharmacy First service, particularly around common conditions like, well, uncomplicated UTIs, urinary tract infections.
Exactly. So if you are tuning in from Oxfordshire, Berkshire, or Buckinghamshire, and you've got questions about Pharmacy First or managing UTIs, seriously, get in touch with them. Community Pharmacy Thames Valley is there to support you.
Definitely reach out. Okay, so today's focus is getting right into the details of the patient group direction, the PGD, for treating these uncomplicated UTIs.
Specifically, the one that lets pharmacists supply nitrofurantoin under the NHS England Pharmacy First service. We're really going to zero in on the inclusion and, crucially, the exclusion criteria.
Yeah, the aim here is for you, the listener, to come away feeling really solid on who you can help under this PGD, and just as importantly, who needs a different approach. It's all about safe, effective care.
Absolutely. Confidence in applying these guidelines is key.
Right. So let's start with the basics just quickly. UTIs, what exactly are we talking about?
Okay, so a UTI, urinary tract infection, it's an infection somewhere in the urinary system.
Which could be the bladder.
Yeah, most commonly the bladder, that's cystitis.
Mm-hmm.
Or it could be the urethra, the tube carrying urine out, which is urethritis. And more seriously, it can affect the kidneys. That's pyelonephritis.
Got it. And the symptoms patients might come in with. What are the classic signs?
Well, the big one is usually pain or a burning feeling when peeing, dysuria, we call it.
Right.
Also needing to pee way more often than usual, maybe even getting up at night, nocturia. The urine itself might look cloudy.
Anything else? Lower tummy pain?
Yes, lower abdominal pain is common. Sometimes people mention blood in their urine too, or even back pain sort of below the ribs.
Okay, those sound like the typical things to look for. But the guidance also flags that sometimes symptoms can be a bit different, particularly in certain groups.
That's a really important point, especially in older people who might be frail or in patients using urinary catheters.
How might it look different then?
Well, you might not see those classic urinary symptoms as clearly. Instead, you could see changes in behavior, like sudden confusion or agitation delirium sometimes,
Okay.
or maybe new or worsening incontinence, or even things like new shivering or shaking, rigors. It just means you need to be extra vigilant with those patients.
Definitely something to keep front of mind. So let's talk about the specific PGD we're using here. What's the official name and the key reference points?
Right. The full title is Supply of Nitrofurantoin Capsule Tablets for the Treatment of Urinary Tract Infection, UTI, under the NHS England Commissioned Pharmacy First service.
That's quite a mouthful.
It is. The current version to look for is 1.2, and it's been valid since January 31st, 2024. Always check you're using the latest version.
Good practice for any PGD. So this document basically gives pharmacists the authority to supply nitrofurantoin.
Yes, but only authorized, registered healthcare professionals, pharmacists included, and only if every single condition laid out in that PGD is met. It's very specific.
And competence is mentioned too. Pharmacists need to show they know what they're doing.
Absolutely. You need evidence of competence. The PGD points towards the CPTE, the Center for Pharmacy Postgraduate Education, their Pharmacy First Service self-assessment framework as one way to demonstrate that.
Okay.
And pharmacy owners, the contractors, they also have a duty to make sure their staff are competent, familiar with the pathways, the service protocol, the PGD itself. Training might be needed.
Right, so it's a shared responsibility for ensuring competence. Okay, let's get to the heart of it. Who can we treat? The inclusion criteria.
First off, informed consent. Always. The patient has to understand and agree.
Makes sense. Then what?
Then it's about demographics. It's specifically for non-pregnant females aged between 16 and 64 years old.
16 to 64. Non-pregnant females. That narrows it down straight away. What else needs to be true for them to be included?
Okay, crucially, they must not have a fever right now. And no fever in the last 48 hours either.
No recent fever. Got it.
And they need to have those signs and symptoms suggesting a lower UTI, the cystitis type picture we talked about.
Yeah.
The diagnosis should follow appropriate primary care guidelines referenced in the PGD.
Right.
And one final check for inclusion. They haven't used nitrofurantoin for a UTI in the past 3 months.
Okay, so female,
Yeah.
16, 64, not pregnant, no fever now or recently, lower UTI symptoms, and no nitrofurantoin in the last 3 months. That's who might be eligible.
Precisely. Those are the essential inclusion gates.
Now, for the flip side, which is arguably even more critical for safety, the exclusions,
Yeah.
who cannot be treated under this PGD, this list looks pretty extensive.
It really is, and for very good reason. Patient safety is paramount. So let's break it down. Age and gender first, we've sort of covered this, but anyone 15 or under or 65 and over is excluded, and males of any age all need referral.
Clear cut. What about pregnancy and breastfeeding?
Both definite exclusions. If someone is pregnant, thinks they might be, or is currently breastfeeding, they cannot be treated under this PGD. They need referral to a prescriber.
Straightforward enough. Then we get into immunocompromised individuals. This section seems quite detailed in the PGD.
It is, and it needs careful reading. The PGD distinguishes between severely and non-severely immunosuppressed patients. But importantly, both groups are excluded from this PGD.
Okay, so any level of immunosuppression mentioned here means exclusion.
For the purposes of this PGD, yes. So, severely immunosuppressed includes things like specific blood cancers, acute or chronic leukemias, aggressive lymphomas, especially within 12 months of remission.
Right.
It also includes ongoing follow-up for chronic lymphoproliferative disorders. People with HIV/AIDS, if their CD4 count is below 200, that's a measure of immune cells.
Okay, specific conditions and thresholds there.
Yes, and primary or acquired immune deficiencies affecting certain white blood cells, like having a very low lymphocyte count, or disorders where those cells don't work properly.
What else falls under severely immunosuppressed?
Stem cell transplants. Anyone who's had an allogeneic from a donor or autologous their own stem cell transplant within the last 24 months.
2 years.
Yeah, and even if it was longer ago than 2 years, if they're still on immunosuppressant medication for it, or if they have graft versus host disease, they're still considered severely immunosuppressed here.
So, transplant history needs careful questioning. What about medications that suppress the immune system for other reasons, like autoimmune diseases or after organ transplants?
That's another big category for exclusion. Anyone currently getting or who has had in the last 6 months immunosuppressive chemo or radiotherapy.
6 months for chemoradio.
Right. Also, immunosuppressive therapy after a solid organ transplant. And anyone who's had certain targeted therapies for autoimmune conditions within the past 3 months.
3 months for those targeted drugs.
Yes, the PGD lists examples like JAK inhibitors, biologics like rituximab, TNF inhibitors, interleukin inhibitors, those very specific immune modulating drugs.
It seems like a lot of common treatments for autoimmune conditions could fall into this.
They could, yes. And it goes further. Also excluded under severely immunosuppressed are people with chronic inflammatory diseases who've had specific steroid treatments recently.
Steroids always need careful checking, don't they?
Definitely. So, moderate to high-dose steroids for more than 10 days in the last month, or long-term moderate dose steroids for over 4 weeks in the last 3 months.
Okay, specific doses and durations matter.
They do. And also certain non-biological oral drugs like methotrexate, azathioprine, mycophenolate, especially at higher doses or combinations within the last 3 months. And finally, even a short course of high-dose steroids if it was for more than a week in the previous month.
Wow, that is incredibly detailed. It really hammers home why a thorough medication and condition history is vital. You mentioned the PGD also refers to just immunosuppressed individuals not meeting the severe criteria.
That's right. And they are also excluded and need referral to a prescriber. It's a blanket exclusion for immunosuppression under this PGD.
But it does clarify some things that don't count as immunosuppression for this purpose.
Yes. Importantly, it says things like replacement steroids for adrenal insufficiency, or topical, inhaled, or injected steroids for local conditions. Those generally don't exclude the patient under this PGD. That's a helpful clarification.
It is. Okay, moving beyond immunosuppression, what are other key reasons for exclusion?
Well, an obvious one is known allergy or hypersensitivity to nitrofurantoin or any of its ingredients. That's a definite no.
Of course.
Also, if someone physically can't take oral meds problems absorbing them or difficulty swallowing tablets or capsules, the PGD isn't suitable.
Practical considerations. What about previous or current antibiotic use?
Yes, if a patient is already taking prophylactic antibiotics to prevent UTIs, they're excluded. Or if they've had any antibiotic for a UTI within the last 3 months.
3 months again. Okay. What if someone gets UTIs frequently?
Recurrent UTIs are an exclusion. The PGD defines this as 2 or more episodes in the last 6 months or 3 or more in the last 12 months. That pattern needs further investigation, so referral is needed.
Right.
And also, if they've already tried an antibiotic for this specific UTI episode and it hasn't worked, you can't then use this PGD. That's considered a treatment failure requiring reassessment.
Intense. Are there exclusions if the symptoms might not actually be a straightforward UTI?
Yes, definitely. If the patient has abnormal vaginal discharge, if you suspect an STI, or if the symptoms seem more like urethritis, perhaps related to sex or irritants, or even genitourinary symptoms linked to menopause, those all need different assessments, so they're excluded from this PGD pathway.
Okay. What about signs the infection might be more serious, maybe affecting the kidneys?
Absolutely. Critical exclusion point. Any sign of potential pyelonephritis that's the kidney infection means immediate exclusion and referral.
And what are those signs again?
Things like loin pain, so pain in the side or back near the kidneys, new or different muscle aches, shaking, chills, rigors, a temperature of 37.9 degrees Celsius or higher, nausea or vomiting.
Got it. Any of those flags means stop.
Stop and refer, yes. Also, as we mentioned for inclusion, any history of fever or chills within the last 48 hours is also an exclusion criterion.
Okay. And if someone just seems generally very unwell?
Yes, if they appear systemically unwell, or if you suspect sepsis, that life-threatening reaction to infection, that's an absolute exclusion and needs urgent, usually emergency referral.
What if there are known complications with their urinary tract or previous treatment issues?
Excluded. So anyone with a known complicated UTI that means associated with structural or functional issues in their urinary tract, or maybe they're already under a urologist's care.
Right.
Also excluded if they have a known history of a previous UTI that was resistant to nitrofurantoin, or even if they just tell you they've had resistance to any antibiotic for UTI, but there are no records to check, you still exclude based on that self-report.
Better safe than sorry there. Catheters.
Any current urinary catheter use is an exclusion indwelling suprapubic or intermittent self-catheterization. All excluded.
Okay. And recent travel or hospital stays.
Yes, that's in there too. Hospitalization in a foreign country within the last 3 months, or a UK hospital stay of more than 7 days in the last 6 months, both exclusions, likely due to concerns about potentially resistant bacteria.
That covers a lot of ground. Are there any specific underlying medical conditions listed as exclusions?
There are a known history of porphyria, G6PD deficiency, anemia, diabetes, both type 1 and type 2.
Diabetes is an exclusion, both types.
Yes, both types are listed. Also, folate deficiency, vitamin B deficiency, peripheral neuropathy, electrolyte imbalance.
Okay.
And significantly, chronic kidney disease stages 3B, 4, or 5. That's defined by an eGFR, a measure of kidney function, less than 45. So you'd need to know or check their kidney function ideally.
That eGFR of 45 is a key threshold then. Anything else?
Just one more specific one. If they've had the oral typhoid vaccine very recently, less than 3 days before symptoms started or within 3 days after.
Wow. Okay, it is crystal clear that you need a really detailed chat with the patient about their symptoms, their history, their meds, everything, before even thinking about using this PGD.
Absolutely. Thorough assessment is non-negotiable.
The PGD also mentions some specific cautions, even if a patient isn't strictly excluded.
Yes, a few important ones. Visible blood in the urine hematuria. If it's present, you can still treat the uncomplicated UTI under the PGD if they meet all other criteria, but you must strongly advise them to see their GP if the blood persists after the UTI clears up.
So, treat but advise follow-up. Good point.
Yeah, and there's a general caution for using nitrofurantoin in people with existing lung disease, liver problems, neurological disorders, or significant allergies because they might be more prone to side effects. Always counsel on potential side effects.
And thinking about the actual tablets or capsules, we need to consider the other ingredients too.
Exactly, the excipients. Things like lactose, sucrose, fructose, sorbitol, aspartame. You need to be cautious if the patient has known intolerances or conditions like PKU. Always check the SPC, the summary of product characteristics for the specific brand you're supplying.
Right, good reminder to check the specific product details. So, putting it all together, if you assess someone and they hit one or more of these exclusion criteria, what are the essential next steps?
First and foremost, document it. Clearly record in the patient's clinical record why they were excluded from the PGD supply.
Documentation is key. Then what? Referral.
Yes, follow the appropriate referral pathway. If PGD treatment isn't right, but they do have urinary symptoms maybe suggestive of vaginal discharge, urethritis, or menopause issues, give supportive advice like self-care measures and refer them to a prescriber, usually the GP, for assessment.
Okay. And for the more serious exclusions?
If it's known or suspected pregnancy, any level of immunosuppression we discussed, or a suspected STI, that needs an urgent referral to a prescriber GP or maybe a sexual health clinic, depending on the issue.
urgent referral for those groups.
Yes. And if the patient seems systemically unwell, but you don't think it's sepsis yet, or if they have those new signs of an upper UTI or kidney infection, they need an urgent same-day assessment that would typically be via their GP or an out-of-hours service.
Same-day assessment for unwell or upper UTIs.
Correct. And finally, the most critical one. If you suspect sepsis at any point, it's an immediate, urgent referral straight to A&E. No delays.
Blue light referral for suspected sepsis.
You got it.
Got it. These referral pathways are so crucial for making sure patients get the right level of care quickly. So wrapping this up, what's the absolute take-home message about navigating these inclusion and exclusion criteria?
The key message is meticulous adherence. Sticking rigidly to both the inclusion and these very detailed exclusion criteria is non-negotiable. It's how we ensure patient safety and make sure we're only using this PGD for genuinely uncomplicated UTIs where it's appropriate within Pharmacy First. Pharmacists have such a vital role here, but a huge part of that role is knowing when not to supply under the PGD and knowing exactly how and where to refer that patient instead. Safety has to come first, every single time.
Couldn't agree more. And don't forget the simple self-care advice too, right? Even if referring, we can still advise things like drinking plenty of fluids, using simple pain relief like paracetamol.
Absolutely. That self-care advice is valuable for everyone experiencing symptoms, regardless of whether they get antibiotics from us or need referral. It empowers the patient.
Great point. And one final reminder, especially for our listeners who are pharmacy owners across Oxfordshire, Berkshire, and Buckinghamshire.
Yes.
If any of this raises questions, if you need support implementing Pharmacy First, or just want to clarify anything about managing UTIs under this PGD, please reach out to Community Pharmacy Thames Valley.
They really are there to help you get the answers and guidance you need to feel confident and provide the best possible service to your patients.
Fantastic. Well, thank you for joining us for this deep dive. We really hope breaking down these PGD criteria has been helpful and gives you that clarity needed for managing uncomplicated UTIs safely and effectively through Pharmacy First.